So we have genetics research, we have proteomic research. So what are the proteins that are being developed that might be affecting addiction? My area that I've had interest in is in connectomics, how the brain talks to itself. And what we're finding, and this is a white matter issue, not a gray matter. So we learned in neurology, white matter, with gray matter lesions associated. What we're seeing here is that you do not find a signature gray matter lesion in the area of addiction. What we have been able to demonstrate is that the brain's ability to communicate with itself is affected. And so what we're doing is a number of advanced imaging techniques. And we would love to partner with you on that. Again, this is the world's largest collaboration. And why I think it's important is the more we understand about the biology of addiction, we can decrease the stigma. Because it's not that people actually choose this, that it's a chronic illness that we need to treat. Because the stigma, I think, really, really complicates the treatment. People don't want to go into treatment because of the stigma. The family doesn't want to. So I think the more we understand the biology, that this addiction is truly a brain disease that affects the biopsychosocial aspect of the patient, then I think that we're able to do, and it's, again, we need many, many samples. So what we're looking at is the combination of genomics, and there are a number of very important candidate genes that we've identified. We can actually screen for them. Very simple clinical screening we could do in the clinics, very easy to do. A high school student could help do the screening. And then looking at white matter connectomics, particularly looking at the amygdala and the hippocampus and the white matter connections to the prefrontal cortex, which are largely mediated through dopaminergic activity. So I think there are many, many opportunities for us to work together on this. And we can do a lot of the analysis because we have a bit more in the way of supercomputer technology, but we work together as equal colleagues in trying to understand this. But I really believe that we really need to look at the biology and then how it impacts on the clinical care of patients and their families.
Oh, now we have good questions. Abdurrahman.
What about the role of cannabidiol in treatment of opioid addiction? And is there any promising drugs for treat opioid addiction?
It's an excellent question. So the question was the role of cannabinoid oil in the treatment of addiction. This is a very controversial area. I don't think we have enough of the science to really answer that. There are many reports that we're seeing in the literature over the past few years talking about the role of cannabinoid oil in treating addiction. And then we have other reports that say not so much. My opinion is there are likely some individuals who would be able to benefit from cannabinoid oil, but not all. So this is where we need a lot more research, because I believe in some individuals we might actually make it worse. Some, it might show some improvement and be part of an effective treatment strategy, and some probably no effect either way. We don't know which patients are likely to benefit from it and which patients are likely to get worse. So this is why we need big clinical trials with good epidemiologic prospective. So it's again, we're seeing more and more reports in the literature. I don't know we have the final answer yet, but I think this is an important area. Again, it helps us to understand the biology behind addiction. So excellent question. The matrix model you mentioned, actually that is our, matrix is, that's our group. So the matrix is Western U, we write grants together. So the matrix group, we can bring them over here. You can hear it right from the Dan George who developed it. He reports to me. So I can say, come over and help work with our Egyptian colleagues.
I think one of the areas of interest that I've been in contact with in work as well, mindfulness. And I actually met Dr. John Kabat-Zinn and other professors there in Mindful Institute. Did you have any experience with the mindfulness role in treatment of drug addicts?
Significant. So my son, who's also in psychiatry, as was my father and grandfather, there's probably a gene to want to become a psychiatrist. We just haven't found it yet. That's my son's, one of his areas of he did his thesis was in mindfulness. I think it's a very important part, maybe one of the most important. And again, when we talk about addiction, we talk about, medications, but it's like a good soup. A good soup is not one ingredient. A good soup is many ingredients mixed together at the right way. So I believe mindfulness and motivational interviewing are critical. And we incorporate those into our training to get some experience. So we actually have, on some of the online, they'll have a patient and you'll observe and it will stop and then the student can pick, and then based on what they pick, it will give a different response. It's computer adaptive learning. So mindfulness is very, very important. We use it all the time. I think it's one of the most effective. I must say that although the 12-step programs, AA, are very, very popular and I think have an important role, I have some concerns with some of the AA issues. I think some of it is excellent, but I can't say I buy all of it. We use bits and pieces. The support is good. Bringing in spirituality, I think, is very good. Some of the issues, I don't think fits every patient, but mindfulness, motivational interviewing, very important. I would love to see how it varies in a different culture, how it works here in Egypt, because you have very different cultural beliefs. And does it make it better or worse? But in my belief, it's one of the most important pieces.
We have actually experienced, we applied a program here for drug addicts, for those who stay for 4 weeks in patients, and we compared between those who entered in the program, mindfulness, we got a program, we translated it. Mm-hmm. And we imaged their brain before and after, and we compared this for those who didn't enter in this, and it was a thesis and the thesis, and there was another collaboration with somebody in Germany, and it was a very good result of brain changes, functional, and we are working now on how the structure changes after 4 weeks. With increased craving and things.
It's so important because we think that if you don't take a pill, it's not real. But there's very good data to show that effective psychotherapy, as far as the brain concerned, is just like effective treatment affects how the brain works. What we've had some good success is combining motivational interviewing and MAT with CBT, the combination of treatments. We found that in many of our addicts, psychodynamic therapy is more challenging for the addict because of the level of denial. Not that it can never work, but what we found is motivational interviewing along with combinations with a kind of a modified CBT for substance abuse can be very effective. And again, there's very good data, if you look at the Enigma data, showing that you're changing the brain, so this is an effective treatment strategy. So it's very good studies, and I think we need to expand those. Thank you.
حد عنده سؤال بالعربي عايز يسأله من الإخوة الأخصائيين أو من الزملاء؟ حد عنده سؤال بالفرنساوي عايز يسأله؟
My question is, during the whole meaning of the word here in Egypt, we do sudden discontinuation of substance and symptomatic treatment for the withdrawal symptoms. We cannot afford for methadone or Suboxone or something. So my question is there is any way that midway between here and USA, like giving methadone, Suboxone for the first few days to overcome the withdrawal symptoms and then continue our program, or it doesn't work?
That's a very good question, because the idea is, do you get an advantage of using Suboxone or methadone and have it, it's certainly a little easier for the patient. Now the question is, if it's easier for the patient, does it affect the long-term outcome? And that's a very good question. I don't know if there's anecdotal reports. I don't think we have really good data. There's certainly no overwhelming data to show that the use of medication-assisted treatment naloxone, Suboxone, methadone. It's certainly easier for the patient, but I'm not sure anyone can demonstrate that you must use that to get a better outcome. I think it's where, again, I think what we're going to find is there's probably a group of addicts who that will make it easier so that you can have more effective treatment. I don't believe it's a one-size-fits-all. I mean, if you wear a size 42 shoe, someone gives you a 48 or a 38, not so good. I think we have to get the right size to fit the patient. And I think some patients, there might be an advantage to using, but there's no data to show that by not having methadone, you're not going to be as effective. The key is you need to get them detoxed, get them through physically, but the key really is the long-term treatment. So what happens at the back end is probably a lot more important than what happens at the front end to just get them off the medication, get them detoxed. But it's an excellent research question.
I would like to ask about unfortunately I didn't attend, but the discussion is very stimulating. I'd like to ask about the programs about the addiction female addicts. The pregnant female addicts.
Oh, yeah.
During pregnancy, and what is, if there is research about this area, caring about the mother and the child during this very critical area, which could be a turning point in the outcome for the offspring.
I actually didn't talk about that during the lecture, but I have significant experience. That's one of the areas I researched when I was in the NIMH. So it turns out with women in addiction, women are more likely to have an adverse effect and become addicted when they use in the late luteal phase, those 2 weeks before the onset of menses. You know, we know about PMS and PMDD. It turns out that biologically, we have changes in pharmacokinetics and pharmacodynamics, the metabolism and distribution of drugs of abuse in about 8% of women worldwide, not just in the US, so 5 to 8%. So women have some very interesting and unique biological as well as psychological. We know oftentimes women, their responsibility is the children and the household. So we can't factor out the psychosocial from the biological. We know that the response to most treatments, including psychosocial, varies to some degree on menstrual cycle phase. And what that has to do is in the neuroendocrine cascade, from the hypothalamus down to the gonadotropins to the gonadosteroids, estrogen, gonadosteroids, feed back onto the POMC gene in the base of the brain, which has a direct impact on metabolism. So that issue, there's much work. In fact, many of the studies that are done, if you don't control for menstrual cycle phase, your data is somewhat flawed. Now, the other part of your question is a very tragic one, but we know that women who use, babies are born addicted. They detox at delivery. Very, very, very tragic scenario. We're trying to follow a cohort of babies who were born. There was one study that I was involved with over 20 years ago now, looked at women who were cocaine addicts, and we were able to follow their children for 7 years. And what we found of those children who were born of mothers who were using cocaine, 8 times the likelihood to develop ADHD. They were much more likely to develop substance abuse themselves later in life. We believe that was a sensitization kindling phenomenon that we see, for example, Bob Post's work from many years ago. So we know that mothers who abuse, very, very toxic. Not only do they detox at delivery, but they change the biology of the brain. And again, the thing that we've seen most of the literature has been dramatic increase in ADHD, usually manifesting around 8 to 12 years. We were able to follow them out about that long. So this is a very, very important area. Working with OBGYNs and the role of substance abuse, we know that substance use during the first trimester has the greatest impact on organogenesis. So that depending on when they were using, will have an impact. Last trimester, the infants were born with addiction, but we seem to have less changes in organ development. But this is a very, very, very important area that is, I think, quite honestly is understudied and needs to be a clinical tool. We need to be working with our colleagues in the OB clinics and screening and then following those children. It's very tragic to me that a child is born, but I think all the more reason that we need to intervene as early as possible, working with our child psychiatrists and our pediatricians and our neonatologists. Very, very important area.
They continue in this area. We don't see addicted females with pregnancy and giving birth to addicted children or addicted babies. We don't see this in Egypt. What's the cultural difference? Abortion is legalized in Europe and the States, and the American ladies, for example, are not keen for children. And why they keep children, why they keep pregnancy after addiction?
Well, actually, under President Trump, not my favorite guy, but he has actually changed. So abortion, they're trying to get rid of it. It was the Roe v. Wade was the legislation many years ago that legalized abortion. It's actually, they're trying to turn that around. So what I think would be a very important study, it seems that when the woman is using and how much they use has an effect. But this is why I say it's such an important area for research, because the reason that you're saying that the women don't use when they're pregnant, or
if they are pregnant, in Egypt they go for abortion immediately.
Oh, so you can get an abortion in Egypt?
Yes.
You're right.
In Egypt, illegal abortion.
Oh, wait, illegal abortion. Well, I mean, if the baby's aborted, then you're not going to see, obviously. But the problem we see is many women will start using, and when they find out they're pregnant, they stop. But they've already been pregnant for 6, 8, 12 weeks. So a lot of the damage has been done. So, but this area of drug use, and drugs are different. We know cocaine versus opioids versus, that not all drugs are the same effect on the fetus. So this is a very, very important area that I think has been understudied. And I think what we need to do is to partner with the OB nurses, with obstetricians, with pediatricians, psychiatrists, child psychiatrists, family physicians. This is a very important area that is not anywhere near as well studied as it should have been.
I think we have a small project concerning this hearing with the pregnant female addicts in Egypt, and actually it needs start with raising the awareness and the knowledge about the OB, even physicians, because and the pediatricians, because it is extremely neglected area, and they tend to overlook, and even they don't ask about the history of the substance abuse. But what you added to me more, that it is not about taking care about the area of pregnancy and giving birth, and also we have a deficiency concerning who will care about these offsprings after delivery. But you add more that it needs more follow-up.
Yes.
Just to take care about these offsprings for the future.
And the other thing that we know is that women who are addicts, they don't take care of themselves as well. They don't go to their OB appointments. They don't take their prenatal vitamins. Their diet might not be very good. They're not sleeping well. So it's not only the drug, but it's all the things associated with being an addict. They're not taking care of themselves. And we know that not taking care of yourself is not taking care of your unborn baby. So this is why we need good data, because there are many factors that we need to go in. So if a woman is an addict, but is eating well, is sleeping well, is going for her prenatal visits, is that going to be different than a woman who does not take care of herself and shows up, ready to deliver and have to not conceive? So these are very, very important questions, but I think you're right. We cannot stop at delivery, or we need to follow these children and make sure that because there might be the ability, if we intervene earlier, to decrease the downstream, the long-term effect. So we need these prospective trials. We need to identify these children as at risk so that we can develop some appropriate interventions earlier on, which actually would be cost savings, because it's much easier to treat earlier than when they themselves become addicts.
Professor Noah is responsible for the National Survey of Drug Addiction with
Beautiful.
MOH, and they did a sample of over 100,000 Egyptians, and those results I provided you with Jonathan was from those studies.
So I think those are the types of trials we need, big, 100,000, 200,000, but we have to make sure that we collect the data properly, or we end up with type 1 and type 2 statistical error. So once we see were they addicted, but then we need additional study. The age, younger women who are addicted and deliver seem to be different than a woman in their 30s or older. Nutrition, sleep, socioeconomic status, history of other mental illnesses, depression, psychosis, anxiety. These are data, so good data, we need to get as many demographics as we can, and it's difficult when you have large studies, but the more we can get, we can understand the relationship between these variables and then long-term outcome measures. And we would love to work with you on collecting these data and then analyzing them. But we have to be cautious to get as much as we can. If not, we might come up with conclusions that were really better addressed by looking, well, it wasn't the opioid, it was the fact that she was, not taking care of herself, not eating properly, under a lot of emotional stress. Emotional stress is a very significant toxic impact on the fetus. Emotional stress because, increase in cortisol levels, that we know mothers who are highly stressed during pregnancy, for whatever reason, their babies have a whole host of increased physical illnesses related to the hypercortisolemic state that the infant lives in, during gestation.
It will be our pleasure.
Thank you very much. Thank you for the speakers. Thank you, Sir Barwon. Thank you, Professor Mack. And thank you for the audience and the wonderful discussion. I think we have a small buffet waiting for us.
Is that okay? I had to show, but I'd rather get around the audience.